Welcome back to the Deep Dive. We're here again to really dig into some complex biology and make it accessible.
That's the goal. Today we're tackling something absolutely fundamental: growth factors and the receptors.
Right, this is the body's internal communication network, isn't it? The text messages cells send to each other.
That's a great way to put it. These signals, these growth factors, or GFs, they dictate pretty much everything a cell does: live, die, divide, move. It's how we maintain tissues, fix injuries.
And crucially, how things can go wrong, like in cancer.
Exactly. So that's our mission for this deep dive. Unpack these protein signals, look at the different families, how the receptors work, and importantly, why knowing this is so vital for modern medicine.
Okay, let's dive in, starting with the basics. What exactly is a growth factor?
So fundamentally, they're proteins,
Yeah.
usually small, soluble proteins found outside the cell. Their job is to find a specific receptor on a cell surface and basically trigger activity inside. They stimulate signaling pathways, turn genes on or off.
So they're the initial spark.
Precisely. They boost cell survival, they encourage growth, they push cells to divide.
And the name growth factor seems straightforward, but you're saying it's more complex. Our sources mention they do more than just make cells grow.
Oh, absolutely. The name is almost, well, a bit limiting. Yes, they drive proliferation, getting cells into the cell cycle. G1, S, G2, M phases. They help overcome blocks in replication.
And keep cells alive too, right? Preventing apoptosis.
Critically important. They actively suppress programmed cell death. So survival is as much their job as growth. And think about division. It needs resources. GFs ramp up the synthesis of everything needed: DNA components, proteins, lipids for membranes. The works.
So if a cell's going to divide, the GF gives the green light on all fronts.
Pretty much, yeah. But here's the complexity kicker you mentioned. They also regulate a lot of non-growth activities. This is key. Things like cell migration, literally getting cells to move from one place to another. Think wound healing or embryonic development. Also, differentiation, that's cells specializing, becoming a liver cell versus a skin cell, and just generally boosting a cell's ability to make stuff, its synthetic capacity.
Wow, okay. So they're not just hitting the accelerator for division, they're also providing the GPS coordinates and the job description.
That's a fantastic analogy. They really are conductors of the whole cellular orchestra.
So the GF is the message. How does the cell actually hear it? You mentioned receptors.
Right. It's the classic lock and key. The growth factor, the key, has to bind to its specific receptor protein, the lock, which sits on the cell surface.
And that binding event is the trigger.
Yes. It causes a change in the receptor shape, a conformational change that starts the signaling cascade inside the cell. And the type of receptor, specifically its enzymatic activity, really determines how that signal is processed.
Okay. And for the factors mainly driving growth, what's the dominant receptor mechanism?
The vast majority, the real engines of proliferation, signal through receptors that have intrinsic tyrosine kinase activity.
Tyrosine kinase, let's break that down. Kinase means it adds a phosphate group, right? Like a molecular switch.
Exactly. And tyrosine kinase means it specifically adds that phosphate to the amino acid tyrosine on target proteins inside the cell. This phosphorylation event is the immediate result of the GF binding, and it flips the internal switch to on-an. It's a very direct, very powerful way to kickstart that internal cascade.
Built for speed and power. Got it.
Okay, so that lays the groundwork. Shall we dive into some specific families, starting with those major players using the tyrosine kinase system?
Let's do it. First up.
Let's talk about epidermal growth factor, EGF, and transforming growth factor alpha, TGF-alpha. They're often discussed together because they're functionally very similar.
Okay, EGF and TGF-alpha, what do they do?
They're classic mitogens. They stimulate cell division. Sources: mainly macrophages and epithelial cells. They target hepatocytes, liver cells, fibroblasts, connective tissue cells, and various other epithelial cells.
And our sources highlight EGF in wound healing.
Yeah, it's crucial there. It helps epithelial cells migrate across the wound bed and promotes the formation of granulation tissue, that sort of rough scaffold for new tissue.
And the receptor story, they share one.
They both bind to receptors in the EGF receptor family. The main one is EGFR1, which you might also see called ERBB1, or most commonly just EGFR.
EGFR.
Yeah.
That name rings a bell from cancer biology.
It absolutely should, because EGFR is probably the best studied example of how a normal communication system can go haywire and lead to disease. It perfectly illustrates the concept of proto-oncogenes.
Okay, let's get into the mechanism. GF binds to EGFR.
Yeah.
What happens next inside the cell to, say, grow?
So the binding causes two EGFR molecules to pair up. It's called dimerization. They physically come together in the membrane.
Like holding hands?
Sort of, yeah. And when they dimerize, the tyrosine kinase domains on the inside of the cell activate each other. They phosphorylate each other, cross-phosphorylation.
Turning each other on.
Exactly. And this activated dimer becomes a docking platform. It recruits loads of other proteins from inside the cell, phosphorylates them, and boom, the signal to divide goes racing down multiple pathways towards the nucleus.
But under normal conditions, it's tightly controlled. No EGF, no dimerization, no signal.
Precisely. The switch is off unless the specific key, EGF or TGF-alpha, is present.
Okay, but the pathology alert in our sources says EGFR mutations or amplification are really common in nasty cancers, lung, head, neck, breast, brain. How does that happen? How does one mistake cause cancer?
That gets right to the heart of what a proto-oncogene is. A proto-oncogene is a normal gene involved in growth signaling, like the gene for EGFR. If that gene gets a specific kind of mutation, a gain-of-function mutation, it can become an oncogene.
Gain of function, meaning it does its job too well or all the time.
All the time. Imagine a tiny change, maybe just one amino acid swapped in the receptor protein structure that makes the receptor think a growth factor is bound even when nothing is there. Or sometimes the cell just makes way, way too many copies of the normal receptor. That's amplification.
So the receptor gets jammed in the on position.
You got it. It's constantly dimerizing, constantly self-activating, constantly shouting, grow, 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 inside the cell, completely ignoring any external stop signals. That relentless, uncontrolled proliferation is cancer.
And this isn't unique to EGFR1, right? The related receptor, HR2.
Exactly the same principle. HR2, which is technically ERBB2, is another member of the family. It doesn't bind EGF directly, but it likes to dimerize with other EGFR family members. When it's overexpressed, meaning there are far too many copies on the cell surface, which happens in about, 15–20% of breast cancers, it leads to hyperaggressive signaling.
And understanding that specific jammed-on mechanism for HR2 is why we have targeted therapies like Herceptin, right?
Absolutely. That discovery revolutionized treatment for HR2-positive breast cancer. It's a direct line from basic science discovery to life-saving therapy.
Incredible. Okay, next, tyrosine kinase player.
Let's move to hepatocyte growth factor, HGF, also known as scatter factor.
Scatter factor. That name implies something different, maybe less organized growth. Movement.
You're spot on. It signals movement. HGF is made by fibroblasts, endothelial cells, mesenchymal cells. It is mitogenic for some cells, like in the liver, hence the name hepatocyte GF, lung, kidney. But its real claim to fame, the scatter part, is its powerful ability to make cells migrate and invade surrounding tissues.
So it tells cells to break ranks and move out.
Essentially, yes. It causes them to loosen their connections to each other and crawl across surfaces. This is vital in development, shaping tissues. It acts as a morphogen, and it's crucial in wound repair, getting cells into the damaged area.
And it also needs activation. The source mentioned pro-HGF.
Right. It's made as an inactive precursor, pro-HGF. It needs to be cleaved, cut by specific enzymes called protease, usually found at sites of injury or inflammation, to become active HGF.
Smart design.
Good.
Keeps it localized. And its receptor.
Its receptor is MET-T. And guess what? MET is also a receptor tyrosine kinase.
Sensing a pattern here.
Definitely. And sadly, MET-T often follows the same dark path as EGFR. It's frequently overexpressed or mutated in certain cancers, particularly kidney and thyroid papillary carcinomas. So naturally, MET-T is another major target for cancer drug development.
Makes sense. Okay, who's next in the lineup?
Let's talk platelet-derived growth factor,
Right.
EGF.
Platelet-derived. So it comes from platelets, the clotting cells.
Primarily, yes. It's stored inside platelets in little packets called alpha granules, and it gets released immediately when platelets activate during blood clotting. So it's one of the very first signals blasted out at a wound site. But other cells make it to macrophages, endothelial cells, smooth muscle cells.
Receptors. Also tyrosine kinases.
Yep. It binds to PDGFR alpha and PDGFR beta, both receptor tyrosine kinases.
What strikes me about PDGF is its dual role mentioned in the source. It makes cells grow, but it's also strongly chemotactic. What does that mean?
Chemotactic means it attracts cells. It sends out a chemical come here signal. So PDGF does two critical things at once. It stimulates the proliferation of key repair cells, fibroblasts, smooth muscle cells, endothelial cells, but it also acts like a powerful magnet, drawing those same cells, plus inflammatory cells like neutrophils and macrophages into the injury site.
So it calls in the cleanup crew and the construction workers.
Perfect analogy. It recruits the macrophages to clear debris and fight infection, and then brings in the fibroblasts and others to start rebuilding the tissue. PDGF is like the site foreman, initiating recruitment and construction simultaneously. It's essential for coordinating that early wound healing response.
Very efficient. Okay, moving on to a big one, especially in cancer and eye disease. Vascular endothelial growth factor, VEGF.
VEGF. Probably the most famous pro-angiogenic factor. Angiogenesis meaning the formation of new blood vessels.
It's actually a family of related proteins.
Yes, there's VEGF-A, MOS-B, CD, and also placental growth factor, PLGF. But VEGF-A is the main driver of angiogenesis in most situations we talk about, like wound healing and tumor growth.
And its core job is building blood vessels.
Everything needed for it. It makes endothelial cells, the cells lining blood vessels, migrate, divide, and sprout new capillaries.
The source mentioned its original name was vascular permeability factor. Why is that important?
Because that's how it works partly. VEGF makes existing blood vessels leaky, more permeable. This helps plasma proteins get out into the tissue, forming a scaffold for migrating endothelial cells, and allows inflammatory cells easier access. It also causes vasodilation, widening the vessels.
But that leakiness can be a problem too, right? Like in leaky retinal vessels in eye disease.
Exactly. That permeability is great for wound healing, but terrible when it causes fluid buildup, edema, under the retina in macular degeneration, for example.
What triggers VEGF production? This seems like something the body would want tight control over.
The most potent trigger is hypoxia, low oxygen levels.
The ultimate stress signal.
Right. When cells aren't getting enough oxygen, they activate a master switch protein called HIF1, hypoxia-inducible factor 1. HIF1 goes into the nucleus and dramatically ramps up the production of VEGF mRNA, telling the cell to make lots of VEGF protein.
So the cell is basically screaming, "I'm suffocating. Build more blood vessels to bring oxygen."
That's precisely the message. It's a fundamental survival response. PDGF and TGF-alpha can also induce it, especially at inflammation sites.
And the receptors for VEGF, let me guess. Tyrosine kinases.
You got it. VEGFR1, VGFR2, and VGFR3. VGFR2 seems to be the most important one for mediating the actual angiogenic effects, the sprouting and proliferation.
And this direct link between hypoxia, VEGF, and vessel growth is why tumors hijack it so effectively. They outgrow their blood supply, become hypoxic, crank out VEGF, and trick the body into building them new vessels.
That's the deadly cycle. Tumors co-opt this normal survival mechanism for their own growth and spread.
Okay, one more major tyrosine kinase family to cover. Fibroblast growth factors, FGFs.
Right, FGFs are a big family too, over 20 members. Our source highlights a few key ones: FGF1, acidic FGF, FGF2, basic FGF, and FGF7, which is also known specifically as keratinocyte growth factor, KGF, because it strongly targets skin cells.
And their functions, repair-oriented again.
Very much so. They're chemotactic, drawing in fibroblasts. They're mitogenic for fibroblasts. FGF2, BFGF, is also a potent stimulator of angiogenesis, like VEGF. They also encourage the production of extracellular matrix proteins, the stuff that forms the tissue scaffold. KGF specifically makes keratinocytes migrate, divide, and differentiate, essential for skin repair.
And they signal through. Wait for it.
4 different receptor tyrosine kinases, FGFR1, 2, 3, and 4.
Okay, pattern confirmed. But the source mentions something unique about FGF storage, something involving the ECM.
Yes, this is really fascinating and highlights how the local environment interacts with growth factors. Unlike many GFs that just float around after being secreted, FGFs, especially FGF2, bind very tightly to heparan sulfate proteoglycans within the extracellular matrix, ECM.
Heparan sulfate, those are complex sugar chains attached to proteins, part of the ECM structure.
Exactly. So the ECM acts like a reservoir holding on to the FGFs. They're stored there, inactive or latent.
So the matrix isn't just passive scaffolding. It's actively holding on to these potent growth signals.
Precisely. The FGFs are only released when the ECM itself is broken down, for example, by enzymes called proteases that get released during wounding or inflammation. This keeps the FGF signal highly localized right where the tissue damage is occurring. It's a brilliant way to ensure the signal is delivered only when and where it's needed.
A physical tether linking damage to the repair signal. That's elegant.
It really is. It shows that the ECM is far more than just structural support.
Okay, we've covered the big tyrosine kinase players, EGF, HGF, PDGF, VEGF, FGF, all driving growth, movement, vessel formation. But it can't be all go, 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 right? There must be breaks in the system.
Absolutely essential. Uncontrolled proliferation is disastrous. Which brings us to a really important and mechanistically distinct growth factor, transforming growth factor beta.
TGF-beta. The name sounds similar to TGF-alpha, but you're saying it's different.
Very different. And a major exception to the tyrosine kinase rule. TGF-beta signals through its receptors type I and type 2, which have serine and threonine kinase activity.
Serine, threonine kinase. Okay, so it adds phosphate groups, but to different amino acids, serine and threonine, not tyrosine.
Yeah.
Does that change the downstream signaling much?
Dramatically. Instead of triggering those complex branching tyrosine kinase cascades, the activated TGF-beta receptor complex primarily phosphorylates a specific family of intracellular proteins called SMADs. Yep, SMADs. These phosphorylated SMADs then partner up, travel directly into the nucleus, and act as transcription factors binding to DNA and regulating the expression of specific target genes. It's often a more direct route from the receptor to gene regulation compared to many tyrosine kinase pathways.
Interesting. And the effects of TGF-beta? The source calls it pleiotropic with a vengeance, meaning it does many, often contradictory things.
That's the perfect description. TGF-beta is the master of context-dependent effects. It can be beneficial or detrimental depending on the cell type, the environment, and what other signals are present. It's incredibly complex.
So what are its main roles, conceptually?
If you had to boil it down, you could think of TGF-beta as having two major, often conflicting jobs. One, it's the primary driver of scar formation and fibrosis. Two, it's a crucial brake on inflammation.
Okay, let's unpack the scar formation part first. How does it drive fibrosis?
It's the master architect of scars. It powerfully stimulates cells, especially fibroblasts, to churn out massive amounts of ECM components, collagen, fibronectin, proteoglycans, the building blocks of scar tissue.
So it tells cells to build the scar matrix.
But that's only half the equation. It also prevents the breakdown of that matrix. It inhibits the enzymes that normally remodel tissue, the matrix metalloproteinases, MPs, and simultaneously ramps up the production of their natural inhibitors, the TIMPs, tissue inhibitors metalloproteinases.
Wow, so it's a double whammy. Build more matrix and stop the demolition crew from clearing any of it away.
Exactly. So in situations of chronic injury or inflammation, think chronic liver disease, lung fibrosis, kidney disease from hypertension. TGF-beta is the bad guy. It drives that relentless, progressive scarring that eventually destroys organ function. It's trying to heal the persistent injury by walling it off with scar tissue.
A repair mechanism gone wrong in the long term.
Precisely. But then there's the other side of the coin. Its absolutely vital anti-inflammatory role.
Right. If it drives scarring, why do animals engineered to lack TGF-beta signaling suffer from terrible, widespread inflammation?
Because TGF-beta normally puts the brakes on the immune response. It actively suppresses the proliferation and activity of lymphocytes, like T cells and B cells, and other inflammatory cells. It helps terminate the acute inflammatory response once the threat is dealt with.
So it prevents the immune system from going overboard.
Exactly. Without TGF-beta, inflammation just keeps raging, leading to autoimmune-like damage. So it's this incredible paradox. You need it to stop inflammation, but too much of it, especially chronically, causes debilitating fibrosis. The balance is incredibly fine.
Heal the wound, but don't let the healing process itself become the disease. A very tricky regulator.
The trickiest, perhaps.
Okay, we've got the signals, the GFs. We've got the receivers, the receptors, both tyrosine and serine kinases. How does the cell actually execute the command to divide? Let's connect the signal to the action, the cell cycle, and the role of the extracellular matrix.
Right, because receiving the signal is just the start. All these pathways, whether from EGF or HGF or even TGF-beta, which can sometimes inhibit the cycle, ultimately converge on the machinery that controls the cell's progression through its life cycle.
Getting cells out of their resting state, G0, and into the active phases, G1, S, G2.
Exactly. And progression through these phases is tightly regulated by checkpoints, ensuring everything happens in the right order. The key regulators here are proteins called cyclins and their enzyme partners, the cyclin-dependent kinases. CDKs.
Cyclins and CDKs, the gatekeepers of the cell
Or
cycle.
that's a good term for them. The CDKs are kinases, enzymes that phosphorylate target proteins to drive the cycle forward, but they're only active when bound to their specific cyclin partner.
And the cyclins are named because their levels go up and down cyclically throughout the process.
Precisely. There are different cyclins for different phases. Cyclin D, cyclin E, cyclin A, cyclin B, and their appearance and disappearance orchestrates the timing.
So how do growth factors connect to this? Do they trigger the production of cyclins?
Yes, that's a major way they work. For example, when a growth factor like EGF binds its receptor and activates those tyrosine kinase pathways, one key downstream effect is boosting the production of cyclin D.
Okay, so GF signal leads to more cyclin D. What does cyclin D do?
Cyclin D partners up with its specific CDKs, CDK4 and CDK6. This active cyclin D CDK46 complex then phosphorylates crucial target proteins, most famously the retinoblastoma protein RB.
Phosphorylating RB, that's a key step, isn't it? The restriction point.
It's the major checkpoint in G1. Phosphorylating RB essentially unlocks the gate, allowing the cell to pass the restriction point and commit to replicating its DNA in S phase. Without sufficient cyclin D CDK activity, the cells stay stuck in G1 or G0.
So growth factor signal cascade matters cyclin D production, mass CDK activation, mass RB phosphorylation, mass commitment to divide.
That's the core pathway for entering the cycle. And then other cyclins take over cyclin E for S phase entry, cyclin A during S and G2, and cyclin B for triggering mitosis. It's a tightly choreographed relay race.
Ensuring everything happens once and only once, in the right order.
Absolutely. But this whole process doesn't happen in a vacuum. The cell is sitting within and interacting with its physical environment, the extracellular matrix, ECM. And the ECM isn't just passive goo.
We already touched on this with FGF storage. The ECM as an active participant.
Hugely active. It provides obvious mechanical support, of course. And it acts as a scaffold for tissue renewal. You need an intact basement membrane, a specialized layer of ECM for organized regeneration, like in the skin or gut.
But it also regulates proliferation more directly.
Yes. Besides storing factors like FGF, it can also present growth factors to cells more effectively, or even play a role in activating latent factors like HGF. And crucially, cells have to physically sense the ECM to respond properly to growth factors.
How do they sense it? Through what receptors?
Through receptors called integrins. Integrins are cell surface proteins that directly bind to ECM components, things like collagen, fibronectin, laminin.
So they're adhesion receptors anchoring the cell.
Yeah.
But they also signal.
Yes, that's the key insight. Integrins connect the external ECM to the cell's internal cytoskeleton, providing structural linkage. But when integrins bind the ECM, they also trigger intracellular signaling cascades, similar to growth factor receptors.
So the cell is listening to two types of signals simultaneously. The soluble GO signal from the GF and the physical you're-on solid ground signal from the ECM via integrins.
Exactly. It's called signal convergence. Think of it like this. The growth factor gives permission from headquarters to build. The ECM integrin signal is the local zoning permit confirming the foundation is stable and suitable for building right here.
And both signals are needed for proper proliferation or movement.
In many cases, yes. The signaling pathways from GFs and integrins overlap and cooperate. A cell might get a growth signal from EGF, but if its integrins detect that the ECM is degraded or inappropriate, it might not divide or might undergo apoptosis instead. Both chemical and physical cues are integrated.
Let's revisit those heparan sulfate proteoglycans again, like the ones that bind FGF. They're not just storage depots, they help the handshake.
They absolutely do. Besides storing FGF in the matrix, similar molecules on the cell surface, like syndekins, can bind growth factors and chemokines. They act like co-receptors. They can trap a GF, like FGF2, near the cell surface, increasing its local concentration and efficiently handing it off to its high-affinity FGFR tyrosine kinase receptor.
So they make the signaling more efficient and reliable.
Exactly. They're facilitators, ensuring the message gets delivered effectively. The ECM is constantly talking to the cell, and the cell is constantly listening.
This detailed map factors, receptors, kinases, cyclins, ECM, integrins, it all leads inevitably to the clinic, right? Understanding this is key to therapeutic targets. Because when this communication goes wrong,
it's often the root of major diseases, especially cancer. Uncontrolled GF signaling, receptors stuck in the on position due to mutations. These are hallmarks of malignancy. So, logically, blocking these hyperactive pathways has become a central strategy in modern medicine.
let's look at the successes. Targeting those tyrosine kinase receptors like the EGFR family, how do we do it?
We have two main strategies generally. First, monoclonal antibodies. These are large proteins designed to bind specifically to the outside part of the receptor, like EGFR or ADR2. They can physically block the growth factor from binding or prevent the receptors from dimerizing.
So they stop the signal from starting,
Yep.
like putting a cap on the antenna.
Pretty much. Examples include cetuximab for EGFR and trastuzumab, Herceptin, for HER2. The second approach is small molecule inhibitors. These are drugs, usually pills, small enough to get inside the cell. They target the internal tyrosine kinase domain of the receptor, jamming the catalytic machinery so it can't phosphorylate anything, even if it dimerizes.
So they block the switch itself inside the cell.
Right. Drugs like gefitinib or erlotinib for specific EGFR mutations in lung cancer, or lapatinib, which targets both EGFR and HER2 kinase domains.
This allows for very targeted therapy based on the specific molecular flaw in a patient's tumor.
That's the goal of precision medicine. And the same logic applies to other tyrosine kinase receptors. You mentioned MET, the HDF receptor, being amplified in kidney and thyroid cancers.
Yeah.
So naturally, there's intense research and clinical trials ongoing for specific MET inhibitors, trying to shut down that scatter factor signaling that promotes invasion and metastasis.
Okay, let's shift to VEGF. Blocking angiogenesis, starving the tumor, seems like a powerful approach. How has that panned out?
It's been a huge area of progress. The main approach here is using monoclonal antibodies that directly bind to and neutralize the VEGF-A protein itself before it can even reach its receptor. Bevacizumab, Avastin, is the prime example.
So you mop up the signal molecule itself.
Exactly. By reducing the amount of active VEGF, you inhibit the formation of new blood vessels that tumors desperately need to grow and spread. It's approved for several cancers, including colon, lung, kidney, and brain tumors, often used in combination with chemotherapy.
And this anti-VEGF strategy has had incredible success in ophthalmology too, right, for eye diseases.
Transformative success. Diseases like wet age-related macular degeneration, AMD, and diabetic macular edema are driven by abnormal, leaky blood vessel growth in the retina, spurred on by VEGF. Injecting anti-VEGF drugs directly into the eye, drugs like ranibizumab, Lucentis, or aflibercept, Eylea, can stop this leakage and neovascularization, preserving and sometimes even improving vision for millions.
It's amazing how understanding one molecule, VEGF, unlocked treatments for both cancer and blindness.
It really highlights the power of understanding these fundamental pathways.
Our source also mentioned a fascinating link between VEGF biology and a pregnancy complication, preeclampsia, something about a soluble receptor.
Ah, yes, SFLT1. This is a beautiful example of molecular pathology. SFLT1 is essentially a chopped-off version of the VEGFR1 receptor. It lacks the part that anchors it to the cell, so it floats freely in the bloodstream.
A soluble receptor, what does it do?
It still has the binding site for VEGF, so it acts like a decoy receptor, a molecular sponge. It soaks up free VEGF in the circulation.
Preventing VEGF from reaching its real receptors on endothelial cells.
Exactly. Now, pregnant women normally need healthy VEGF signaling to maintain the vasculature of the placenta and their own blood vessels. In preeclampsia, which involves high blood pressure and kidney problems, levels of this FFLT1 decoy receptor are often dramatically elevated.
So too much SFLT1 mops up all the VEGF, leading to endothelial dysfunction, mimicking a VEGF deficiency, which causes the symptoms of preeclampsia.
That's the leading hypothesis, and there's strong evidence for it. It shows how disrupting the balance of these factors, even with naturally occurring inhibitors, can cause serious disease.
Fascinating. Okay, finally, let's return to the therapeutic challenge of TGF-beta. Given its dual role, pro-fibrotic but anti-inflammatory, how do you target it?
That's the million-dollar question, maybe billion-dollars. We know TGF-beta drives devastating fibrosis in chronic lung, liver, and kidney disease. So the obvious thought is, block it.
But if you block it completely,
you risk unleashing uncontrolled inflammation and potentially autoimmunity because you've removed that critical immune brake. We saw that in the animal models lacking TGF-beta.
So a simple blocker drug might trade one problem for another.
It's a serious concern. The therapeutic goal here can't just be brute force inhibition. It has to be more nuanced, more about modulation. Can we selectively block the downstream SMAD pathways leading to collagen production while leaving the anti-inflammatory pathways intact? Or can we target it only in specific tissues or contexts?
That sounds incredibly difficult.
It is. It's at the cutting edge of drug development. trying to tease apart the different arms of TGF-beta signaling to specifically target the pathological fibrosis without compromising its essential protective roles. It's a huge challenge, but the potential payoff for treating fibrotic diseases is enormous.
A real Gordian knot for drug developers.
Absolutely.
Wow. What an incredibly detailed tour of the cell's command and control. Let's try to boil down the core messages for everyone listening.
Okay. At the simplest level, growth factors are protein instructions: grow, move, specialize. Receptors are the antennas on the cell that receive these instructions.
And the most aggressive growth signals tend to use that high-speed tyrosine kinase switch inside the cell. EGF, HGF, PDGF, VEGF, FGF families.
Right. But healthy tissue function needs balance. So we also have crucial regulators like TGF-beta, which uses a different serine ethero-9 kinase system. TGF-beta's job is complex. It drives scar formation, which can be bad in excess, but it also puts the brakes on inflammation, which is essential.
And none of this happens in isolation. The cell's physical environment, the extracellular matrix, ECM, is a critical partner. It provides structure, stores signals like FGF, and talks back to the cell via integrin receptors, ensuring the cell responds appropriately to its location.
Signal integration is key. Cells listen to both the chemical messages, GFs, and the physical context, ECM.
We've seen how understanding these pathways led to targeted therapies, especially in cancer and eye disease drugs that block overactive receptors like HER2 or mop up excess signals like VEGF. Real breakthroughs.
Definitely. But that leads us to the final thought, maybe a challenge for you to consider. We're getting really good at developing these sophisticated therapies that block specific signals, anti-VEGF, anti-EGFR, etc.
Silencing the shouting cell.
Exactly. But are we truly winning, or are we just treating a symptom very effectively? If a tumor is hypoxic and screaming for VEGF, blocking VEGF might slow the tumor, but have we addressed the underlying hypoxia that triggered the scream in the first place? Or the chronic inflammation driving fibrosis?
So are we just silencing the alarm without putting out the fire?
That's the provocative question. Are we controlling the consequence, or are we getting to the root cause? As molecular medicine advances, thinking about targeting the triggers, the hypoxia, the inflammation, the initial tissue damage might be the next frontier, beyond just blocking the resulting signals, something to chew on.
A fantastic point to end on, looking beyond the signal to the reason it's being sent. Thank you. This was an incredibly insightful deep dive.
My pleasure. It's truly fascinating biology.